Thank you, everyone, for joining us at the Project Censored radio show. We are very glad right now to be joined by Sam Sewell, who's a certified professional midwife and advocate for reproductive justice. In 2004, she co-founded the Texas Equal Access Fund, a nonprofit that assists low-income pregnant folks in covering the cost of abortion services. She has served on the board of the Virginia Midwives Alliance, NARAL Pro-Choice Virginia, the Younger Women's Task Force, and the Arlington Commission on the Status of Women. Sam owns her own midwifery practice, Sage Midwifery, where she provides inclusive, evidence-based, trauma-informed care and works to build a community for families to thrive. Sam, thanks so much for joining us.
Thanks for having me.
So, since folks just recently celebrated the birth of a Jewish lefty in Palestine many moons ago, I felt that it was an apt time to talk about birthing, but more specifically birthing people as opposed to the babies. Now, the United States is the wealthiest nation in the world and has an abominable record for maternal mortality. According to data by UNICEF, the U.S. ranks higher in maternal mortality than nations such as Saudi Arabia, Iran, Kuwait, and Serbia, basically higher than several places we've either bombed or engaged in economic warfare against. And those numbers are actually a few years old. They're from 2017. The CDC actually points out that in 2020, maternal mortality rose to 23.8 deaths per 100,000 from 19 in 2017. So that's a lot of data points. But Sam, as somebody who moves outside, but still parallel to the medical industrial complex, can you give us some ideas as to what's going on here?
It's not a straightforward answer. And I think that's where we have difficulty in our very straightforward binary black and white society. A lot of it is the healthcare system, right? There aren't enough providers with enough time to treat everybody as an individual and look at what is happening in somebody's life, right? So obstetrics is looking for problems, and an obstetrician will spend at most 15 minutes a visit with somebody, whereas in midwifery we treat the whole person. It's a very holistic approach, and we're spending most of the time at least an hour per visit with our clients. And I think our healthcare system is stretched too thin, and nobody wants to give the time to really address what's going on and start listening to pregnant people when they feel like something's wrong, and also providing adequate postpartum care, which is a huge issue. A lot of maternal mortality is from postpartum hemorrhages or preeclamptic seizures, hypertension. So it's a huge systemic failure.
Yeah, absolutely. And I appreciate that you said that there's not a straightforward answer, because I think sometimes people are they're too eager to find a simple answer and then end up going after something that won't fix the holistic issue. And I kind of want to zoom in a little bit, because you're in Northern Virginia, and which is just, for those who don't know, is just across the water from DC. And in fact, you practice midwifery in DC and Maryland as well. A few years ago, DC came actually under harsh criticism for having the highest rates of maternal mortality in the nation. So much so that the DC city government established a maternal mortality review committee to basically figure out what was going on. And I looked at a report, and they found that most of the deaths occurred in wards 7 and 8. And for folks who don't know, wards 7 and 8 have the highest percentage of non-Hispanic Black residents in the district. And so, Sam, I also wanted to get your take on this, because just like everything else in U.S. society, there seems to be a very stark racial component to this issue.
Absolutely. Across the country, Black women, Black birthing people, are 3 times more likely to die from childbirth complications, either prenatally, during childbirth, or postpartum, compared to their white counterparts. And that is 100% a huge contributor to the rising mortality rate, right? And I think, if we're being honest, it is systemic racism. It is not educating in medical school and midwifery school about the basics of why Black people are at higher risk for these things. So in medical school, they're learning that Black women have an increased chance of developing preeclampsia. That's just what they are told. So then they're treating Black women like they're already sick, or if a Black person is saying something is wrong, they're just writing it off, and they're waiting for, and I've experienced this in my own practice several times, they're waiting for the symptoms to become so severe that then they get their attention. Whereas when, for example, when I speak to my clients, and also we call them clients, not patients, which is about like erasing the hierarchy between provider and client. I say, yes, you are an increased risk of developing preeclampsia, but that is not just because you're Black. That is because of intergenerational trauma and allostatic stress and how that affects the entire body on a molecular level, and having ancestors that were enslaved and still living in a society where you're worried that your child could be shot by a police officer down the road, right? Like it is all connected, and our healthcare system does a very good job of ignoring any connections, right? Like we just skim over. I'm sure the providers are burnt out, but that's also not an excuse. I'm sorry, it's just not. And I think for the so-called woke white midwives, like just knowing about the racism existing is not enough. Like you have to transition from being an ally to an accomplice in anti-racism work. Like just being a midwife is not enough anymore. Like, unfortunately, you have to do more work. You have to take more steps to try to confront what's right in front of you. It's a Herculean task, right? To ask, first of all, any like medical society to address this in a real way. But even, like I'm a CPM in my school, they did educate on it, but it still wasn't enough, right? Like, I don't know if I would be feeling this way if it weren't for my history in social justice work. And I think that's a problem. Like it's, like even home birth midwives are having issues. So I think like we have to start centering people of color in our care. And when something pops up, believing them. That's another, we're not trusting pregnant people. We're like, oh, it's probably heartburn. You're fine. And it's really sad and it's scary, right? Like I take care of normal, like pregnancies, healthy pregnancies. And my job is to look for things that might arise. And then if certain things come up, I have to transfer care. But sometimes hospitals won't take it seriously if they're not, like I said earlier, like basically dying. If they're not dying, then the hospital's like, that's fine. They can stay home for a little bit. So it makes my task impossible sometimes to be like, legally, I'm not allowed to take care of you anymore, but the hospital won't take you because your blood pressure is only 150 over 100, and they need it to be higher for them to take it seriously.
And I wanted to, this is a perfect transition because I wanted you to talk a little bit about also how the medical system treats a CPM, because just the simple fact that you would have a client and that then you would like to transfer them. Are you allowed to go into the hospital with that client? Like talk a little bit about the issues that arise when you're trying to interact with the medical system.
Yeah. We're allowed to go in. COVID did kind of mess with that a bit because sometimes they'll just be down to one support person allowed. And obviously they're going to choose their partner if they have one to go in with them, or a close family member. But we do go if we're able to, because we kind of we don't have hospital privileges, but we turn into an advocate and kind of a translator of like, this is what they really mean when they're saying XYZ. And they're making this sound scary and emergent, but really you do have like 10 minutes where you can discuss it with your partner and make a decision, right? But I think like the work is all one-sided to build any sort of relationship with hospital providers. And it's gotten easier for me in DC because it's, all the out of hospital midwives, we talk to each other and we're like, oh, this is a good doctor to like have a consult with or something along those lines. But we very much have to prove ourselves. Like my training and education was 6.5 years. I already have a bachelor's in something totally different. And it was all about proving myself and having to see normal physiologic birth and prenatal care and postpartum over and over and over again. And so, yeah, it's kind of like sometimes you feel like you're bowing down to like the patriarchal system. But the reason I chose to be a CPM instead of a CNM, a certified nurse midwife, is because I did not want to be a part of that system. And I knew that I would get a better education for addressing a lot of the issues that we're seeing in this country by getting a CPM training and education.
Yeah, so I want to talk a little bit about that because, of course, it's ironic that they would turn up their noses at you because midwifery actually gives better outcomes when it comes to the health of both the birthing person and the child. So can you talk a little bit about these outcomes and how they differ and why they differ so much from the medical system?
Yeah. We spend time with our clients. I don't know a single home birth practice that's like a baby factory, right? We're usually solo practitioners. Some are group practices, but even still, you can only take so many people per month because we're on call. We don't have like a staff of nurses tending to folks. Like we're kind of doing all of it. And I think because of those boundaries, we kind of afford ourselves the luxury, if I could call it that, of being able to really spend time with people and get to know them and not, like I don't tap out at a birth unless there was a big emergency with my own health. If I'm at a birth, I'm at a birth. I'm not like, I don't have a shift where I'm like, see you later. I'll see you in a week after that baby's out. We stay and we're with you through the highs and lows of birth, and we stay postpartum. We are trained in newborn care, which obstetricians are not, which I think does play a big integral role. Like we see the dyad, right? Like the pregnant person and the baby connection. And I think it affords us just a different angle at care, right? And we talk about postpartum and stress. Everybody is so stressed and anxious right now. I've never seen this many stressed out parents. And they need somebody to talk to. It's as simple as that sometimes. We care with midwives, out of hospital or in hospital, actually, reduces rates of interventions such as induction of labor, episiotomies, don't get me started on those, and cesareans. And also there are better outcomes for babies and moms. There's reduced hemorrhages. There's higher rates of breastfeeding at 6 months postpartum when you've had a midwife care for you. And I think because there's such a huge lack of continuity of care with OBs that those things just don't happen, right? Like they're not counseling on really anything postpartum other than like, I'll see you in 6 weeks. Like your bleeding should slow down. Talk to the LC about lactation, right? We do all of that work and they don't. And there is a place for obstetrics for people that are sick. And I'm thankful for the doctors that are in our area and do take on higher risk folks. But there's a difference between somebody having some sort of illness or disease that predisposes them to certain complications and something that's iatrogenic, which is physician caused, right? Like handling the delivery of the placenta, for example, can cause a postpartum hemorrhage. So that's an iatrogenic hemorrhage versus a different approach that most midwives use, which is being patient and waiting. There's a saying, a good midwife knows how to sit on her hands, right? Like if you see it enough, you know the range of normal and you know when to intervene and when not to intervene. And obstetricians just don't see that. So they're doing all the things Did that answer your question right?
Yeah, absolutely. Well, and I think you kind of highlighted this, and I feel like I read this somewhere, but when I myself was pregnant, that the system looks at pregnancy like it's an illness. And it's obviously not. I mean, unless it is. And then again, like it's good to have people who are good in emergency situations for that kind of thing. But this idea that as soon as you get pregnant, the medical system is like, okay, there's something wrong with you is really
Yeah.
bizarre, and horrifying as well. And kind of in that same vein, I understand that like something that you've also done is that you'll have clients that, as opposed to starting with you from the very beginning of their pregnancy, will come to you as a transfer, kind of going the opposite way. Like they started with OBGYNs and they were like, you know what? No. Can you talk a little bit about like those kind of situations? Like why do they come to you?
That's a great question. Most of the time they're just not satisfied with their care, or they're feeling coerced into things, right? Like 28 weeks is when we check for gestational diabetes, not what does it mean if I do have gestational diabetes? What are my testing options? What happens if I don't? There's no discussion, right? It's just like, we're doing a blood draw today to check for anemia. Okay, there's just no conversation. And I think a lot of people are, actually was thinking about this the other day. I feel like the Me Too movement has had some influence on this, right? Like just coercion and obstetric rape, right? Like that is a thing. I and lots of other birth workers, because we do go to transfers in hospitals. A lot of midwives were doulas before, like watching a provider shove their hand into somebody's body without warning, without consent, the person screaming and saying stop, and that continuing is horrendous. And it just happens all the time, right? Like it's just part of the system, and providers don't even realize that it's wrong, which is a whole other bag of worms, right? So I think it's these moms coming, or they're fear mongered into like going past their due date, and they're like, I have a feeling, and they'll do research and they're like, oh, okay, maybe it's not the end of the world if I go past my due date. And they find a provider who, it's not like we're just like, sure, we'll take whatever, but we educate. It's all about shared decision making and informed consent. We talk like we exhaust all the things, right? We're like, no, but really we're going to talk about nutrition and why that's important for, iron and like preventing hemorrhage and, growing your baby, but also like making sure that you have your nutrients for you postpartum. We exhaust all the things because that's how people can feel empowered, is if they have information. So
Yeah, absolutely. And I think that's another thing, is that midwifery has a holistic perspective. And I think that maternal mortality is due to a lot of issues, but I feel like because the pregnancy is treated as an illness and a problem from the get-go, it gets so like piecemeal, and you're not looking at the holistic person. You're not looking at the whole aspect. Like I remember even hearing that Serena Williams, when she was in the hospital giving birth, she had like a pre-existing bleeding condition or something with her blood. And she was like, hey, there's a problem. And the doctor wouldn't even listen to Serena Williams. Like, so
yeah,
because they weren't looking at the whole person, they were like, I'm just focused on the baby in the vagina. Like whatever else is going on, I don't care. And that is something that seems to be a stark difference. And so I'm curious as well. I mean, I don't even call it the healthcare system in the US. It's really like the sick care system. And in a for-profit sick care system like the one that we have in the US, do you feel like midwifery can ever become mainstream, and like that it would be allowed to become more popular?
I think that could be possible with nurse midwives if we were to model something similar to like the UK. And I'm honestly, I mean, especially considering how like money hungry everybody is, I'm surprised it hasn't happened sooner, because the cost savings of midwifery care versus obstetric care are drastic, right? Like that alone, it's kind of surprising that they haven't been like, oh, but really it's sexism and just the history of how Western medicine demonized midwives in the early 1900s and basically almost eradicated them by 1940. So there would have to be a lot of reckoning, similar to, you know, addressing racial disparities and health inequities, right? And it might just have to be like, you know, people talking to each other and sharing experiences of what their birth was like with a midwife. Yeah, I'm not very optimistic, unfortunately.
It's okay. This is not necessarily the show for optimism.
Yeah.
I'd say it's probably not actually. There's hope, but there's very rarely optimism on this show. But I think that that's an interesting point too, because the basically like the history of midwifery and the rise of the medical industrial complex, like would you see something like this shifting if the US were to adopt like a universal healthcare system? Like, do you see there being better options for midwifery care if profit motive was not like the only motive?
Yeah, I think if we did move to something closer to universal healthcare, that would be seen as an option. But it would have to be a multi-pronged process, right? Like right now, there aren't very many midwives, but in the UK, midwives outnumber obstetricians 3-1. That's bananas. Like, so we would have to do a lot of work to grow midwives. And because we do have different educational pathways to midwifery in this country, it would be all of those different pathways, like making a concerted effort to grow midwives and then help integrate them into the system. Right now, I would never want to have hospital privileges and also be a home birth midwife. Like, that just seems terrifying to me. Because with a hospital comes rules that are oftentimes based purely off of like malpractice insurance, right? And I don't want to make my care decisions because of that. I want to make my care decisions based off of evidence and what the client wants. And that has to be the very first thing that is involved. And I know that there's some places that are working to have, you know, midwife and OB teams together. But, and that works for birth. It's okay for prenatal time, right? Like they're still not getting like the solid prenatal care. But it doesn't work for postpartum because they don't do extra visits, right? Like we've actually increased our number of visits postpartum because there was a need. So now we do 24 hours, 1 week, 2 weeks, 4 weeks, 6 weeks, and 12 weeks. And that's mom and baby. It's not just mom or birthing person. But I don't know if that would ever happen. There are also places that have nonprofit programs aimed at sending a home healthcare worker to postpartum families to check on them. But those are focused mostly on low-income communities. And we know that maternal mortality cuts across all economic statuses, particularly for women of color. So it's one of those things that it would be growing midwives, but also if we ever did make a move for universal healthcare, changing the way we do healthcare in general, right? Like it would just have to change. They would have to like notice that like the model we provide also, it's not just midwives, like we need to be able to have the freedom to provide the model of care that we do. And I don't know if they would do it.
Yeah, no, nor do I. But I think that that's another good point. And when you mentioned like the worker coming to the house afterwards, it also made me think that one of the things that midwifery does is build trust throughout the prenatal period. as opposed to just welcoming some rando to your home that's like, hey, I'm a postpartum person. And it's like, yeah, but you're looking at me as a chart. And again, like the holistic perspective. So what are you missing that might end up, but possibly killing the birthing person, if or just being really stressful or really painful or what have you. And I kind of want to end on that point, the postpartum issue, because I mean, some people call it like the fourth trimester, which I remember when I said that, my mother-in-law was like, wait, try is 3. I'm like, yeah, no, it's kind of like a play. Never mind. But and then, but it goes to show you like how much most people in the US don't think of postpartum as like a continuation of the pregnancy, like in terms of the physical and, oh my God, the mental and the emotional. But
Mhm.
can you talk about, like, with regards particularly to maternal mortality, and of course the health of the baby, like what are we looking at in terms of postpartum that midwifery offers that the medical industrial complex just completely misses?
Yeah. First of all, it's educating about what to expect prenatally, right? Like we're not talking about postpartum after you've had the baby. We've been talking about it well in advance. Um, because I mean, especially these days, people are freaking out about like what kind of parenting they want to do and like how to get sleep and are they going to all those questions. Um, and a lot of times it's just talking and getting to know folks, right? Just like you said, it's not as simple as like looking at somebody's chart and seeing they have a history of anemia and maybe consider this thing because of that. It's so much more complex. Um, Knowing somebody's history of trauma is very important. Um, for example, like somebody has a history of obstetric trauma, and then postpartum, they have headaches, and then it turns out they have hypertension, and they need to go back into the hospital, but they are resisting and they're not telling their provider because they don't want to go back. So if it's somebody that knows them and has that relationship, they're much more likely to open up. And then also we would go with them too, which also helps. Um, but yeah, it's we're not cogs in a machine, right? Like we're individuals and everybody's different. It's like I tell my daughter, like everybody's unique and different, and that's what makes everything so beautiful in this world when there's a lot of crap, right? Um, and I think their obstetrics is missing like the social piece, right? Like domestic violence. Murder is actually one of the #1 killers of pregnant women, but we don't talk about it unless it's October and it's Domestic Violence Awareness Month, right? Like nobody talks about that. And it's, like we do tons of screenings on that, but we're trained to do that. And obstetrics aren't. And if they are, they don't, like take a deep dive, if that makes sense. And like really look at how those things can affect overall health.
Yeah, no, absolutely. And I mean, just thinking about, like, I went in to get an IUD. It was like, I don't know, maybe a month, or I guess like 2 months after I gave birth. And there was this questionnaire, which, like, first of all, I hate questionnaires because they're like one size fits all and it's so dumb. But on the questionnaire, it's like, how's your mental health right now? And it was like, are you stressed? Are you sleeping well? And I'm like, look, I gave birth 2 months ago. Am I sleeping well? What kind of question is that? And then of course they're like, oh, you're not sleeping well, so your mental health isn't great. And I'm like, don't hit the red button or whatever the button is to like bring in like a mommy and me straitjacket. Like it's so dumb. And yet
Yeah.
they're not, like, they don't take the time to talk to you. They're just like, here, fill out this questionnaire and then we'll put you in a little box. And
Mm-hmm.
it's infuriating and so absurd. And
Yeah.
yeah.
And we, we're on call for people, but also we always tell people, even if it's not near their due time or if it's after baby, if you're having a mental health emergency or if your partner is worried you are, please call us. Like instead of worrying alone or letting things escalate, like please call us, because postpartum mood disorders are a real thing. And I'd rather get woken up at 3 a.m. and talk to you or your partner than like find out a week later that you went to the hospital and got ignored and things are still crappy, right? Like it's being available and being able to, and it's the relationship, right? Like that means everything to people, and to be able to just be open and available to people when they need you is huge.
Yeah, I think that relationship is just like you call them clients as opposed to patients. I think that's a huge, that horizontal and that sort of like friendship is something that I think hardly, I would guess like less than 1% of people have experienced in the United States in a hospital setting.
Yeah.
But so Sam, thank you so much for taking the time. Give folks some resources in terms of midwifery or sort of, since you deal with social justice with regards to this as well, some resources for folks that might be useful or interesting.
Sure. Black Mamas Matter Alliance, they deal a lot with reproductive justice issues affecting Black women, and particularly the stark maternal mortality rate and high infant death rates as well in this country. Locally, there's Mama Toto Village in DC, which they have postpartum healthcare workers, and they've got a great team that they send out to families in need in the DC area. The Big Push for Midwives is a great spot to look. CPMs, the kind of midwife I am, are only legal in 37 states. And so they're actively working in different state legislations to help get legal recognition. And then, like look up your state midwife group. Even if midwives aren't legally recognized there is a group working to make that change happen.
Yeah, I think that's very telling. It's only legal in 37 states. Wow. As opposed to the things that are legal in all 50. Oh, good God.
Yeah,
Well, Sam, thank you again for taking the time and giving us some insight into midwifery and maternal mortality.
of course. Thank you for having me.